introductions to all of us. Professor Ghoneim is a scholar and a leader in the field of kidney transplantations, not only in Egypt, but in the Middle East and internationally. He initiated Mansura's Centers for Kidney Transplantations, which Dr. Sayari was just mentioning. And it's an honor to have him. And he would like to speak to us about his research in transplantation of insulin-producing cells derived from human bone marrow stem cells could cure chemically induced diabetes in nude mice. Professor Ghoneim.
ممكن just my slides, please. Okay. كانت مظبوطة. صباح الخير. Thank you very much for the invitation. And don't cut me down, because you started late. And I come from Egypt, but not from Cairo. Cairo is a airbag disaster. I come from Mansura, which is a smaller city on the eastern branch of the Nile Delta. Mansura, the translation is victorious, the victorious. Because 800 years ago, the Crusaders tried to invade Egypt. So they assembled a big army from Germany, France, and England. Now we can consider that the NATO came to Egypt to invade Egypt 800 years ago. But Egypt was strong, and we defeated the NATO at that time, near Mansoura, and hence the name, the victorious. We captured the commander-in-chief, King Louis IX, who became a prisoner of war. So where shall we put the prisoner of war? Egypt was strong, but also civilized. They did not put him in Guantanamo or Abu Ghraib. We put him in the house of the judge of the city. 3 months later, the Europeans gathered a big amount of money as ransom to get back their king. So Egypt got lots of gold and money from Europe. Unfortunately, later, Egypt became a decaying third world country. And as you know, with developing countries, the money will go back secretively to European banks. So what we got from Europe went back from Europe. A small amount remained in Mansoura, with which we built the Urology and Nephrology Center, whereby I am privileged to work in. After January, we tried to get the rest of our money. Anyway, now, there are lots of possibilities to treat diabetes, starting from diet and ending with transplantation of pancreas or islet cells. And now, stem cells, or conversion of stem cells to insulin-producing cells, is being experimentally tried in many centers. And the sources are listed in the table, could be from the embryo, umbilical cord, adult tissues, like the mesenchymal stem cells, or the induced pluripotent cells. We have opted to use in our experiments the mesenchymal stem cells for these factors listed. Availability, proliferative ability, they are pluripotent, they could be utilized successfully without immunosuppression in an autologous application. The disadvantage is the difficulties in their differentiation protocols. So our experiments were carried out in 2 phases: an initial in vivo production and subsequently an in vivo application. Now, the in vitro production involved harvesting, isolation of mesenchymal stem cells, their expansion, and then at the end of expansion we characterize them, and then differentiation, followed testing of the differentiated cells thereafter. We got the mesenchymal stem cells from the bone marrow. It's easy. And the cell suspension is layered on top of a density gradient solution. And then the most important thing that the cells, or the mesenchymal stem cells, are separated from others by specific characteristics, that they adhere to plastics, the plastic of the culture plates. So this is the, and the adherent cells were expanded. You can expand them. Evidence had been provided that mesenchymal stem cells could be expanded for 50 times without changing in their genetic profile. This is the picture of the mesenchymal stem cells at the end of the expansion phase. They look spindle-shaped like fibroblasts. These were tested by flow cytometry to make sure that they are mesenchymal stem cells, and functional testing by the dietizone staining and immunofluorescence. The mesenchymal stem cells are known to express some surface antigens and lack the expression of others, the hematopoietic stem cells. So we have carried out the flow cytometry, and the results had provided evidence that the specimens that we are having at the end of expansion were really mesenchymal stem cells and not hematopoietic stem cells, since they were negative for markers of hematopoietic cells and positive for markers of mesenchymal stem cells. Staining with TTZ was negative. They did not contain any insulin. And similarly, with immunofluorescence, they did not stain for insulin. Now, differentiation protocol involved 3 phases. An initial phase, all of them in the background, the cells were cultured in a high concentration glucose medium. In the initial phase, we have added mercaptoethanol, which is a known factor that induces PDX1 expression, an important factor in the generation of insulin-binding insulin genes. Second phase, non-essential amino acids, fibroblast growth factors, epidermal growth factors, B27 supplement, and glutamine. Finally, beta-cellulin, activin, and nicotinamide were added. This is the mesenchymal stem cells initially, before differentiation, at the end of expansion. What happens during expansion is a fantastic morphological changes. The cells, after 3 days, 4 days, they tend to adhere to each other, leaving spaces in between. With further adhesion, they form cell clusters with spaces, and then at the end of expansion, they form this one. Clusters of cells totally separated from each other. And this is at the end of 18 days, cell clusters, spheroidal in shape, but containing fibroblast-like stem cells. These cells are gathered together manually by a scraper, and they look like this. And these are the cells, or the cell cluster, that they will be tested for their functional characteristics. The following tests were carried out: DTZ staining, immunofluorescence, reverse transcription PCR, electron microscopy, conventional and functional, and in vitro insulin release in response to increasing glucose concentrations. Staining with DTZ was positive, but it could be false positive. DTZ stains anything that contains zinc. Immunofluorescent staining indicated that on the left-hand side is the positive control. This is our cells, and on the left-hand side is the negative control. Positive for insulin, positive for C-peptide, but with electronic merging. The colors, the green and the red, became yellow, which indicates that the C-peptide and insulin are expressed within the same cells. So this is conventional immunosuppression. Nobody was very happy with these pictures. They said they have to have confocal microscopy. Sorry. Okay. The same thing was carried out for glucagon, but when we have electronic merging of glucagon positive cells and insulin, they were expressed by different cells. The green and the red were not in the same cell. This is the confocal study, individual cells, with one on the upper left corner containing insulin granules by immunofluorescence. And the second one is, this is the red granules, again on the same cell on the left-hand side for C-peptide. And electronic merging indicates that, again, by confocal study, that the insulin and C-peptide are expressed by the same cells. On the other hand, again, glucagon could be expressed and studied by confocal study. These cells, after differentiation, on the left-hand side are the mesenchymal stem cells before differentiation. They were Ki-67 positive, i.e. they indicate their ability to multiply. But after differentiation, on the right-hand side, the Ki-67 was negative, indicating that after differentiation, there is no more division. Alas, they became mature and incapable of further division. The gene expression using the PCR technology was carried out at various phases during differentiation, with one positive control, human islets, and two negative controls, undifferentiated mesenchymal cells as well as lung cells, lung cell line. At the end of differentiation, the expression of endocrine hormones, glucose transporters, pancreatic enzymes, endocrine precursor markers, transcription factors were essentially similar to that of the human islets. Electron microscopy, conventional vacuoles containing small dark particles similar to beta cells. Granules showing electronic dense granules, big ones, similar to alpha cells. And granules surrounded by a thin halo similar to delta cells. When we presented this one, they said this is kaput, this is shit, nothing. Electron microscopy, conventional, cannot be approved as an evidence that these cells are really insulin producing. You have to carry out the so-called immune or functional electron microscopy. Antibody against C-peptides were coated with nanogold material, 1.5 nanogold material. So when the antibody goes into the cell and finds the C-peptide, if it finds the C-peptide, will adhere to the C-peptide and you can see the gold. This is the functional thing. So on the left-hand side here, you can see insulin-producing cells that were prepared in laboratory were positive for C-peptide, which indicates or provides a good evidence of intrinsic synthesis of insulin. Mid slide, undifferentiated mesenchymal cells were negative. On the right-hand side, the positive control, human islets. Again, they show the granules. So we covered this one. Another test that was carried out in vitro, is an in vitro human release, insulin release in response to increasing glucose concentrations. And evidence was provided that the insulin release was related to the glucose concentration in the medium. And similarly, C-peptide release was related to the concentration in the medium. Now, we finished with the in vitro studies, and we went to the in vivo studies. And in the in vivo studies, experimental animal that have to be used was nude mice, 25 grams, nude mice. So we have to induce diabetes, transplant our cells into the renal subcapsular space, and monitor what's happening. And at the end of the observation period, 100 days, we took out the kidney that was transplanted. Nude mice, diabetes was induced by intraperitoneal streptozotocin, and evidence of diabetes was blood sugar more than 350 milligrams for 2 consecutive readings. 4 experimental groups, 1 definitive experimental group and 3 controls. Diabetic animals treated with the culture media, diabetic animals treated with unmodified mesenchymal stem cells, and the definitive group, diabetic animals treated with insulin-producing cells. And lastly, non-diabetic, non-treated animals to serve as a background normal control. We have utilized this technique using 2 thin cannula. One was them, the tip was burned to make a sort of a ball, which facilitates the creation of the subcapsular renal space. Using a surgical microscope with a magnification of 15, what's happening? The procedure was jammed. I'm sorry. Your computers are not good, so I'm sorry. It's not my problem. Huh? This is a bloody computer. You should not use this one. You should not use this. Oh, okay. Anyway, now we have monitored the animals during the observation period, initially for the blood glucose levels. I would like you to follow up. There is no bloody laser. Huh? The green thing, the green, this is the definitive group. After the induction of diabetes, the green comes up, became hyperglycemic. 7 to 10 days after transplantation, the green goes down, became euglycemic. At the end of the observation period, when we took the kidney out, they became hyperglycemic again. This also applies to the C-peptide. The C-peptide in the green until throughout the experimental observation period. The serum mouse insulin in the green was low throughout the experimental period, which indicates that the induction, the diabetes was continuous during the observation period, and there was no regeneration in the pancreata of the diabetic animals. The oral glucose tolerance test was essentially similar to that of normal mice. Kidneys were removed out, and you can see in the upper slide clusters of cells under the renal capsule by hematoxin and DUC. And then the same section stands for immunofluorescence, positive for insulin, positive for C-peptide. Electronic merging indicates again that the C-peptide and insulin are expressed by the same cells. Confocal study of the same cells under the kidney capsule for labeling, for dual labeling for insulin and glucagon. Insulin in red, glucagon in green. This is the experiment on the left-hand side, and this is the positive control, the human islets. Glucagon and insulin are not expressed by the same cells in the islets. So we have also examined the pancreata of these animals, and there was no evidence of regeneration of the islets. Conclusion: the in vitro study provided evidence that adult human bone marrow derived mesenchymal stem cells can be differentiated to form insulin-producing cells. Second, the proportion of the derived insulin-producing cells was modest. 3, the insulin release and content of these cells was small when compared to the human islets. The in vivo experiments had confirmed the in vitro studies. The formed insulin-producing cells did control the diabetes in nude mice. Human insulin could be detected in the sera of the treated animals. The induced euglycemic state was reversed following the removal of the insulin-producing cells bearing kidney. Some proposal for future studies which are carried now indicates or entails optimization of the culture conditions and differentiation protocols to increase the yield and of the insulin-positive cells and enhance their insulin content. And then determination of the optimal number and the best site for implantation of the insulin-producing cells in larger animal models. Shall we put them in the liver? Shall we put them in the deltoid muscles, in the muscles? Shall we do them subcutaneously? Shall we put them in a pouch made by Omentum? This is what we are trying to carry out now. I acknowledge this is important for everybody. It was the first time in Egypt, a charity thing, collecting zakah, is supporting research. And really, this is the Masr al-Khair corporation or group who supported this, our research. And I thank you very much for your attention.
Thank you very much, Professor Ghoneim, for an excellent research work. This paper is open for discussion.
Very clear presentation, Tom. No questions. It's very clear.
If there's no questions to be asked, Dr. Sayari, yes?
I was giving a chance for other people to ask questions they didn't have. It's really very fascinating work, Mohamad Ghoneim. Very fascinating work. I'm very, very proud that this happens in one of our countries, Egypt.
Thank you.
When are you going to start it in human beings? I know you said in the last slide that there are something to sort out, but when do you expect you can use it in humans with diabetes?
Well, lots of groups all over the world, many groups in fact, trying to use embryonic cells, trying to use umbilical source. In Japan, Yanamaka introduced a very fascinating thing. Now we know that embryonic cells undergo a process of differentiation to form specific skin or whatever. He said, all right, why can we reverse the process? And the skin cells or whatever, fat cells, can we reverse them back into the embryonic status? And he did succeed. But his experiments involve gene transduction, gene insertion into these cells using a carrier, lentivirus, so carrying a xenographic material. So many groups are trying. I feel that within 10 years, stem cells will have a definitive place in the treatment of type 1 diabetes or patients with type 2 diabetes requiring insulin, for example. And the interesting thing about type 1 diabetes, and where we know that an important element in the generation of type 1 diabetes is autoimmunity. Mesenchymal stem cells have a property, the so-called immunosuppressive property. So implantation, this is the thought, I mean, this is speculation, of cells, insulin-producing cells from mesenchymal cells, as well as undifferentiated cells, now will provide insulin, and the undifferentiated cells will provide immunosuppression.
Yes, doctor.
سؤال.
السلام عليكم. دكتور أحمد وزنة من النور هوسبيتال مكة نفرولوجيست. Thank you, Professor Ghoneim, for this
أنا ما
interesting.
بسمعش كويس والنبي على حسك، أنا ما بسمعش كويس يعني my age is فين ما فيش فيها سماعات؟ Okay. All right. Yes.
Actually, I will just start by appreciating the work you have done in Mansura Center, because I got a chance to visit you about maybe 3 or 4 years ago, and really I appreciate the research work and the experimental research you did in this center.
Thank you.
With very limited resources, as far as I know. My question is really, as a nephrologist, we face so many inquiries from patients coming to us asking, there is Dr. So-and-so in this country. And
In Düsseldorf.
Huh?
In Düsseldorf. Yeah, I know. This is bullshitters. These are bullshitters in Düsseldorf. There are 1 or 2 centers in Germany and European, who really deceive the patients.
Actually, it's not in Germany.
And look, if you have a publication in a journal, respected one, whereby there is a clinical application has been published, and I am not aware of a publication whereby in a clinical setting, mesenchymal stem cells from whichever source, or insulin-producing cells from stem cells from whichever source, have been as yet applied in the clinical setting.
I have a question, please.
Last question.
Okay, thank you, Turkey. I have a question. It's very nice work, but I have concern about the cells after differentiation. And you are using Ki67, and Ki67 usually indicates proliferative index, but does not mean that these cells will not go on proliferating. And I think this is it's a part of our worry about stem cell proliferation and making tumoral disease. And I think Ki67 is not enough at all to say that these cells are not active.
Okay. You are right about one thing, that the tumor formation is a possible complication, but not from adult mesenchymal cells. But when you use the embryonic stem cells, then the teratogenic possibility is high. We have used mesenchymal cells and from adult tissues, and you can see, although the Ki67 is not a definitive final proof, but the most important thing is when you compare it to the undifferentiated cells. The undifferentiated cells were clearly Ki67 positive. And the differentiated cells were again clearly Ki67 negative. And I think this is, at least in the experimental setting, is an adequate proof.
Thank you very much.
If we transplant these cells and later become tumors, I don't know.
Thank you very much, Professor Ghoneim.
Cheers. Thank you very much.
I think we adjourn now and we'll reconvene in 10 minutes.